Good morning. This is Dr. McDaniel. I'm a board-certified obstetrician, gynecologist in New York City, and this is GYN Corner, bringing all things health-related for women to you. Thanks for joining me here at GYN Corner. It's a lovely Saturday morning, nice and shiny, sunny, bright, warm, not too warm, a little bit of a breeze, so happy to be here. I'm at the horse farm today. This is Jill. She's doing a little bit of warm-up with her horse. They started a little bit ago. So she's doing some warm-up sessions, or I guess routines, with her horse today. And after Jill will be Joy. They do 30 minutes each from 8 to 9 every Saturday. So let's see. I didn't do a presentation yesterday. The office was closed yesterday. Had a lot of running around to do. When the office is closed during the weekday, I tend to take care of a lot of errands. And in taking care of all those errands, I didn't have a moment to just stop and do the presentation. So I'm here today doing the presentation. Previously this week, I spoke about pelvic organ prolapse. Pelvic organs are the bladder with its urethra, the uterus with its cervix, and the rectum with its associated small intestines. And pelvic organ prolapse comes about anytime there is a compromise or a weakening of the pelvic floor, which is the muscular sling or the muscular base that supports the pelvic organs. And when there's a weakening or a compromise of that muscular floor, then the organs that are supported on it will also be compromised. Gravity will do its duty, and the pelvic organs will start to sink, fall. We call it prolapse. It's a herniation or a collapse of those pelvic organs towards the ground. And whenever this occurs, it's always due to some kind of chronic force, some kind of chronic pressure on the pelvic floor. That's often due to pregnancy, to a normal vaginal delivery, obesity, chronic coughing, chronic heavy lifting, constipation. Those are the usual suspects which lead towards stress and pressure on those pelvic organs. And then with the stress and pressure on those pelvic organs, the pelvic organs are compromised. Earlier this week, I spoke about the anterior compartment of the pelvic floor, and that's the bladder with the associated urethra, the signs, symptoms, the diagnosis, and the treatment. And today I'm going to speak about the middle compartment of the pelvic floor. I spoke about the uterus and the associated cervix earlier this week, and the signs and symptoms of the uterine prolapse. It's going to be predominantly lower back pain, lower aching of the back. A pulling sensation is often what people describe. Lower abdominal pressure, discomfort. Given enough time, most women will actually say that they feel a ball inside the vagina. And once they start feeling a ball inside the vagina, they will often have discomfort with intercourse or some kind of pain with intercourse, pressure, discomfort, or difficulty with intercourse, because that ball is the uterus and the associated cervix compromising the vaginal vault. So it's basically blocking up the vagina. It can be halfway or almost completely filling the vaginal length. Oftentimes, given enough time, they will start to notice that there's not just a ball that they feel in the vagina, but they can actually see a ball as it starts to come out of the vagina. So that's pretty common also. Once someone's at that point, that's we have different levels of the uterine prolapse. The first level, it's broken down into mild, moderate, severe, or first degree, second degree, third degree, and fourth degree. First and second are basically mild to moderate. Second and third is moderate to severe, and fourth degree is always severe. So mild to moderate is the cervix has some laxity. It stays in its correct pelvic position unless someone bears down or strains, and then you can see some laxity of the pelvic floor. That's first to second degree. Second to third degree, or moderate to severe, is when the uterus is always compromised. So it's always a little bit lower in the vaginal vault, just with walking around. It's midway, can fall midway through the vaginal vault, and then with any kind of pressure, valsalva, bearing down, stress or strain, the uterus actually is pushed down to the opening of the vaginal vault. And then fourth degree, or just plain old severe, is when the cervix is always either at the vaginal opening. You can see it if you just look closely at the vaginal opening, or it falls completely out of the body. The cervix and the uterus are completely out of the body. That's called a total procedencia, and that's the fourth degree. Sorry, I have allergies today. So those are the varying degrees of droppage or descensus that we will see of the pelvic organs, and those are obviously the symptoms associated with that. So the symptoms associated are the symptoms that go along with slow but sure descensus or falling of the uterus associated cervix into the vaginal vault, and then eventually out of the vagina given enough time. Now the evaluation for that is pretty easy. First you get the history. If she tells you she feels a ball at the vagina, or that she feels a ball coming out of the vagina, you kind of already know what it is. Lower back pain, pressure, ache, discomfort, and or discomfort with intercourse, pressure, ache with intercourse, or difficulty having intercourse. Those are additional predictable signs and symptoms. The evaluation is pretty easy. After that, you already have an idea of what's going on. You put the speculum in gingerly. You can see that the cervix is either already in the vaginal vault or has already come out before you put the speculum in. Otherwise, you put the speculum in. We have what we call half specula, so it's not the full speculum with the up and bottom portion of the anterior posterior blades. We can separate them and just put a posterior or the bottom blade in. So basically, we can pull the vaginal wall downward, take a look, and then have the patient cough a few times or bear down like she's having a bowel movement. Once we do that, we can see if there's actual movement of the cervix and the associated uterus or not. If there is, then we can evaluate that portion of descensus or droppage into the vault and so on. We can also have her stand with her legs open, see if the cervix comes all the way down past the vaginal opening or not, and then if it does, obviously that's third degree to a fourth degree, and if it comes completely out, then she has a fourth degree, a total procedencia. So the evaluation is not difficult. And sorry, I have bad allergies today, lots of coughing today. So the evaluation is not difficult, and the treatment is not super complicated, because the treatment for the most part is the same kind of stages of treatment that we had for the bladder prolapse or the cystocele. So the treatment's going to be potentially vaginal estrogen hormones if she's postmenopausal. We'll try to soften up and tighten up and make the vaginal walls a little bit thicker. And what that also does is it really, for this case, it's not going to help with the prolapse, but it's going to help support potentially a pessary. And the pessary is a little plastic or silicone or silastic mold or device. We have a whole bunch of different shapes that can be used, and what that does is it helps you push it into the vagina, and it helps to hold up the uterus in the position that it's supposed to be, which is the pelvis. So the pessaries, the patients are supposed to place themselves, the pessaries, and you make sure they know how to place it, know how to remove it. It should be washed every couple of days, and it should be removed at night so that when she sleeps there isn't that constant pressure on the vaginal walls. With the vaginal estrogen cream, that will help prevent potentially erosion and pressure on the vaginal walls, because the walls are a little bit tougher, thicker, more pliable, but it doesn't completely 100% eliminate it. So removing the pessary every night is key. Pessaries work very, very well for a person who doesn't want surgery, or perhaps it's mild enough where they're just having a little bit of back pain or pulling. They want some relief from that. They put the pessary in. They can use it every day, every couple of days, whatever their comfort zone is for that. So after the pessary, the next option is surgery. Surgery is going to be what we call definitive, because it's going to be an absolute treatment. There's going to be any issues with the uterus dropping through the vagina or prolapsing again. Surgeries, the main surgery is just a hysterectomy, and most physicians or gynecologists will do that hysterectomy vaginally because the uterus is falling out of the vagina, so it's pretty easy. Just remove the uterus vaginally. That's what it wants to do anyway. It's coming out. It wants to leave the body, so we help it out. Vaginal hysterectomy, with or without removing the ovaries. Now, nowadays, most gynecologists are removing the fallopian tubes, and that's simply because it's been confirmed that the 1% of ovarian cancer is actually not from the ovaries, it's from the fallopian tubes. So most gynecologists will remove the fallopian tubes whether or not they remove your ovaries. Tubes are coming out now because we know it's a potential source of cancer. We're right there. The tubes aren't doing anything if you don't have a uterus, so it's not worth leaving them. So it'll be a hysterectomy. If someone really doesn't want or can't medically is compromised, can't medically support a hysterectomy for anesthesia purposes or surgery time or whatever the reasoning is, then potentially just what's called a Lefort procedure, blocking up the vaginal walls surgically to basically you're sewing up the vagina. Obviously this woman will not be able to have sexual relations, intercourse, once she doesn't have a vagina. But it's for women who cannot tolerate, for one or other medical reasons, cannot tolerate surgery. Then a Lefort procedure, basically closing up the vaginal canal, so you're sewing the uterus up into its correct position. And then years ago, a colpoclesis was done, and that's basically, oftentimes if the uterus and the associated cervix start to fall out the vagina, for whatever reason, the cervix gets longer. So sometimes the uterus is only a third or halfway fallen into the vaginal vault, the vagina, but the cervix is so long, it's like 2 or 3 inches, so it's all the way at the vagina or falling out, so you can just cut the cervix off. That's rarely ever done now. It's kind of not worth it. If you can just do a vaginal hysterectomy, you might as well do it. But it is something that historically was done because it's relatively quick, easy, can be done in the office, and it is in the textbooks and medical journals and such. So it's an option, but it's really not a viable option in 2019 or 2020. It's kind of not worth it. So that's the diagnosis and the management of uterine prolapse, the middle compartment or mid-compartment pelvic organ prolapse. Sorry, allergies are bad today, plus the horse is horrible. So I hope that's been helpful information on pelvic organ prolapse, uterine prolapse specifically. This is Dr. McDaniel. I'm a board-certified obstetrician gynecologist in New York City, Midtown Manhattan. We're just west of the Empire State Building. So if you're in the tri-state area, come on by. I'll be happy to see you, especially anyone who's viewing the Facebook streams. It's great. Please check us out on YouTube. Please press the like button, the follow, subscribe button. The like button, that gives us social proof, makes me feel good that people appreciate and enjoy the information I'm presenting, and it shows others that this is a valuable source of information, so they'll want to check it out if it has some, as we like to say, street cred. And if you follow the Facebook and you follow the YouTube, then you'll get a heads up on information that's being presented when it's being presented. Please check out the podcast if you have any kind of commute on a regular basis, or if you're working in the evening. It's nice to listen to the podcast. Podcasts are just like radio presentations now. So you listen to the podcast. We're on 8 different platforms, the most popular being the iTunes, Google Podcast, and Anchor and Spotify. So please check out the podcast. Please follow, like, subscribe so you can get a heads up on the Facebook's live streams and the YouTube. They're all called GYN Corner, so it's pretty simple. Have a great rest of your weekend, and I will be back on bright and early Monday morning at GYN Corner in Midtown Manhattan. Check out the website page for our office. It's called midtowngyn.com. Thank you. Bye.